Hello everyone and welcome to Meddy Simplified. So in this video we are going to discuss the images related to ophthalmology for various exams. So this video is basically in two parts. The first part contains of some topic and the second part will consist of some more topic. So let's begin. So at the first, basic of anatomy, basic, that is the anatomy of eye. Eye consists of three layers. The outer layer, which consists of two parts, cornea and sclera. The anterior 1/6 is cornea, whereas posterior 5/6 part is the sclera. The middle part is known as uvea. Okay? It consists of iris, ciliary body, which consists of pars pliccata and pars plana, and then we have choroid. And the innermost part, that is the nervous layer, is known as consists of retina. So you can see in this image, this whitish coat, outer coat is the sclera and cornea. Then in this reddish layer is of choroid. Then it continues. Here we can see pars pliccata, iris, and the innermost layer, that is this yellowish layer, is the nervous layer called as retina. Now, very basic thing, that is the rods and cones. So let's distinguish between them so that if all are true about rods and cones and something like question like this comes, we are able to answer. So first thing is, rods are located at the periphery of the retina, whereas cones are located in the center. Rods are in number 120 million, right? Whereas cones are just 6 million. So it is approximately, if you multiply 6 by 20 times more than the cones. Okay, so we have more rods, but the thing is, rods we have only one type, whereas cones are of three types, that is red, blue and green, in which the red is the maximum, that is 65%. Now talking about the function, the rods have function is, it helps in peripheral vision, black and white vision and night vision, whereas the cones, C for cone, C for central, right? So C for cones and C for central. So cone is responsible for central vision, color vision and day vision, because mostly we see colors in day, like if it is black and white, we usually see it in night time. Now talking about the aqueous and vitreous humor. Now aqueous humor, it is located in the anterior segment of eye, whereas the vitreous humor is located in the posterior segment of eye. How do we divide this anterior and posterior segment? I guess by the lens, right? The part in front of the lens is the anterior segment, whereas the part behind the lens is the vitreous, is the posterior segment, and posterior segment consists of vitreous humor, which is a gel-like structure, whereas the aqueous humor is a solution-like structure. The function of aqueous humor is to provide nutrition to the eyeball, whereas vitreous humor, it acts as a shock absorber for the eye. The production of aqueous humor is 2.5 microliter per minute, whereas vitreous humor is produced just once, and it is produced at birth, and it can, if it is lost, it cannot be gained again. And now talking about, if we want to collect some amount of aqueous humor, we want to enter the aqueous humor, we usually go through the limbus. What is limbus? I told you that the outermost part of eye is consist of 1/6 cornea and 5/6 of sclera. So the junction, it is something like this. The junction here is known as limbus, whereas the vitreous humor, if we want to go in vitreous humor, we enter directly through the pars plana. So now let's discuss about some charts. Okay, some charts we'll discuss then, because many of the time question is asked that this chart is used for which purpose, and some question can come in exam. So we'll start from the charts. I know that till this part it is boring, but it's a part of ophthalmology, the basics of ophthalmology, which we should know for any exam. So what we do, this is the Snellen's chart. In Snellen's chart, what we do, we ask the patient or anyone who came for the test to stand at a distance of 6 meters and close one eye and read it. Okay, and normally it is 6/6. If it is a good normal eye, it is 6/6. Now these are two other charts, that is Landau's ring and tumbling E chart. Landau's ring consists of Landau's E is, this both chart are usually used for illiterate people. Now various charts, once again summary. Snellen chart is usually used for normal people. Then we have Landau's ring and tumbling E chart, it is for illiterate people. Then there are some picture charts, also known as Allen chart. It is usually for preschoolers. And we have optokinetic drum, which is usually for child of less than 2 years, and it is used to check the nystagmus in this child. types of ulcer. So here is a table to know the agents causing the type of ulcer. So bacterial ulcer is usually caused by Staph aureus and Pseudomonas aeruginosa. Also sometimes coagulase negative Staphylococcus and Streptococcus pneumoniae may cause corneal ulcer. Whereas the viral ulcer, viral corneal ulcer is caused by herpes family, that is herpes simplex and herpes zoster. Fungal is caused by Aspergillus, Fusarium and Candida albicans, whereas protozoa is usually caused by Acanthamoeba. Now talking about the bacterial ulcers. Most common cause of bacterial ulcer worldwide is Staph aureus, whereas the most common cause of bacterial ulcer in India is pneumococcus, and it shows a typical pattern called as ulcer serpens, which I'll show you now. And the treatment of bacterial ulcers, bacterial corneal ulcer, it's cephalosporin with vancomycin. They are used in combination, or we can use fourth generation fluoroquinones like moxifloxacin as a monotherapy. Now, this is what ulcers serpents look like. Okay, it is a grayish, white or yellowish disc-shaped ulcer occurring near the center of the cornea. You can see it here, right? And it starts at the periphery. This is the starting point. It starts from the periphery and spreads towards the center. And this eye you can see it's so this is what basically ulcer serpens looks like. Now talking about the viral ulcer. Viral ulcer most common. It is also known as dendritic ulcer, right? Because it is most common cause is herpes simplex virus, and the ulcer characteristic of the ulcer is the dendritic ulcer. The corneal sensation is lost in the usually in this kind of ulcer, viral ulcer. The treatment is acyclovir, and this is how basically a dendritic ulcers look like. You can see that dendrites are formed here. Okay, so this is how a dendritic ulcer looks like. Now going further, we'll talk about the fungal ulcer. Fungal ulcer, most common cause is Aspergillus fumigatus. Okay, and the risk factors are chronic use of topical steroids or vegetable matter trauma. Any kind of vegetable it hits in your eye, and there are some fungus in it, and it may cause you a fungal ulcer of the cornea. Now, what are the characteristics of this fungal ulcer? They have feathery margins. Okay, they have a satellite lesion, painless, slow-growing ulcer, and the treatment is natamycin eye drops. So now let's look how the ulcer look like. You can see here the ulcer is having a feathery margin. How the feathers have their margin, that kind of margins is there in the fungal ulcer. Now talking about the ulcer caused by protozoas. It is also known as acanthamoebic ulcer or acanthamoeba ulcer. Most common cause is contact lens. It is a ring-shaped ulcer. This is the specificity of this ulcer. It is a ring-shaped ulcer. It causes pain out of proportion, and the treatment is PHMB. What is PHMB? It is polyhexamethyl biguanide. Polyhexamethyl biguanide. Now, this is how a ring ulcer looks like. Okay. So, in short, we had dendritic ulcer in the dendritic ulcer. We had ring ulcer. We had one more in the starting, that was ulcer serpens. So you should remember those images for the exam. And recently in FMGE exam, last year's FMGE exam, that is December 2019, an image of dendritic ulcer was asked in the exam. Now going further, there is a question, okay, that is most common organism responsible for corneal ulcer in contact lens wearer. So the options are Acanthamoeba, Staph aureus, Pseudomonas, and HSV. Right now I just told you that the most common cause of Acanthamoeba ulcer is contact lens, right? Is contact lens. So now, if we go with that, the people tend to mark answer as Acanthamoeba, but the answer is Staph aureus. So Staph aureus is the organism which most commonly attacks the contact lens wearer, but contact lens is the most common cause of Acanthamoeba ulcer. So if the question is which is the most common cause of Acanthamoeba ulcer, the answer should be contact lens. But if it is the history is given of a contact lens wearer and it is saying he developed a corneal ulcer, then the answer will be Pseudomonas, that is bacterial ulcer, ulcer serpens, not this one. What is this? Acanthamoeba protozoan ulcer. Now talking about the keratoconus. Okay, so in keratoconus, various signs are present. Munson signs. that is notching of the lower lid margin while looking down, right? If when you look down, this lower lid margin will notch. How it looks, I'll just show you within few times. Then Vogt trial seen pressure ring is seen in keratoconus, whereas Kaiser pressure ring is seen in Wilson's disease. So flexure ring, keratoconus, Kaiser pressure ring in Wilson's disease. So this is how a keratoconus, keratoconic eye normally looks like. You can see it here, and this is what I was talking about, the Munson's sign. This is positive in keratoconus. Now going further, let's talk about this two thing, that is Pterygium and Pinguecula. Right? So what is pterygium? Basically, it is encroachment of the conjunctiva to the cornea, right, on the cornea. It is commonly seen in the farmers, and the treatment is of this situation is excision of that pterygium. But the chances of recurrence is very high in this case. Whereas Pinguecula, it is the deposition of fat in the conjunctiva, and it is a brown color spot. Only a cosmetic problem, and no treatment is required for it. Now you can look here in this image, the conjunctiva is encroaching towards the cornea, on the cornea, and this is the pterygium. Whereas this Pinguecula, you can see here a fat brown color spot on the cornea, right? And it is just a cosmetic defect. No treatment is usually required for it. Going further, we'll talk about the allergic conjunctivitis. It is also known as spring catarrh and VKC, that is vernal keratoconjunctivitis, right? It is an example of type 1 hypersensitivity reaction. Hallmarks of allergic conjunctivitis is cobblestone papillae, ropey discharge, Maxwell-Lewin sign, Turner-Trenta spot, shield ulcer, and this is how a cobblestone papillae looks like. You can appreciate it here, the cobblestone papillae. This is seen in allergic conjunctivitis, which is an example of type 1 hypersensitivity reaction. Going further, we'll talk about the trachoma, right? So what is trachoma? It is also known as Egyptian ophthalmia, right? It is also known as Egyptian ophthalmia, and is most commonly caused by Chlamydia, trachomatis A, B, and C. Now, hallmarks of, we have discussed the hallmarks of the allergic conjunctivitis. Now let's discuss the hallmarks of the trachoma. It is Art's line, sagogreen follicles, Hubbard split. Art's line I've already discussed. You can see this whitish line, okay, right here is the Art's line, whereas this is how a sagogreen follicles look like. Sagogreen is nothing but the sabundana which we eat, white color, so it looks typically like that. And whereas if you remember the cobblestone papillae here, it is having outwards growth and it is reddish in color, whereas this trachoma, that is the sagogreen follicle, it is whitish spot, right, inside the margin. And now this is how a Hubbard split look like, dot kind of thing in the iris region. Now the ocular manifestations or infection caused by chlamydia. So this is a table which is very important. It consists, right, chlamydia, three families, that is Chlamydia trachomatis, Chlamydia lymphogranulomatis, and Chlamydia psittacosis. Psittacosis is causing in animals, so we can leave it aside. Now talking about trachomatis and LGV. So in LGV, L1, L2, and L3 causes lymphogranuloma venereum conjunctivitis. That is, and how it is transmitted? It is transmitted from the genitals to the eye. Whereas Chlamydia trachomatis, they have A, B, and C, and A, B, and C is causing hyperendemic trachoma, whereas which is having eye to eye transmission. Whereas D2K is having a paratrachoma. Causes paratrachoma, that is neonatal and adult inclusion conjunctivitis, and it is transmitting from genitals to the eye. Now talking about the FISTO classification of trachoma, F, T, F, T, I, T, S, T, 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 and C, O. Basically it is F, I, S, T, O. So F is for follicles, I is for intense inflammation, S is for scarring, and T is for trichiasis, and O is for opacities. Right, so follicles 5 or more. What are the diagnostic feature? 5 or more follicles of at least 0.5 millimeter of diameter on the upper tarsal plate is the follicles, right? Whereas the intense, that is intense inflammation, it requires urgent treatment, whereas follicles needs treatment and it is an active disease. Scarring, old and inactive infection. scarring will say that this trachoma is old and inactive infection. Whereas trichiasis needs corrective surgery. Trichiasis means presence of at least one trichiatic eyelash. If there is at least one trichiatic eyelash present, we call it as a trichiasis. Whereas opacities, corneal opacities from previous trachoma causes visual loss. So that is how a FISTO classification is there. Now, for elimination of this trachoma, the WHO has adopted a safe strategy, that is S for surgery, A for antibiotics to clear the Chlamydia trachomatis infection, F for facial cleanliness, and E for environmental improvement to reduce the transmission. So these two things, that is FISTO classification and safe strategy, is very important as a community ophthalmology point of view. So it can be asked in PSM, whereas also in ophthalmology. Now talking about these three diseases together, we'll talk about it. So first we'll talk about these are the disorder of eyelid. So first, that is externum hordeolum, which is also called as stye. It is abscess caused by a staph infection, staphylococcal infection in the eyelash follicle associated with the gland of Zeiss. So what we need to remember is that external hordeolum, that is also known as stye, it is a staphylococcal infection, and it is caused at the it is associated with the gland of Zeiss. Now talking about the chalazion, that is Meibomian cyst, it is a chronic non-infective lipogranulomatous inflammation, and it is caused by the blockage of Meibomian gland orifices and stagnation of the sebaceous secretion. It is a painless disease, whereas stye, that is the external hordeolum, is a painful disease. Now talking about the internal hordeolum, it is a small abscess, right? External hordeolum was also abscess, so internal hordeolum is also an abscess. It is a small abscess caused by acute staphylococcal infection of Meibomian gland. Okay, so if the abscess caused by staphylococcal infection is of the gland of Zeiss, so it is external hordeolum, that is stye. If it is at the Meibomian gland, so it is internal hordeolum, and it is more painful than the external hordeolum. That is to be remembered. Now talking about the splashed tomato appearance of the fundus, right? So it is usually seen in CRVO, and it is also known as acute. It is also known as blood and thunder fundus. And the most common cause of CRVO, most common cause of loss of vision in CRVO, that is central retinal vein occlusion, is macular edema. This is also a question many times asked in exam, and this is how a splashed tomato or a blood and thunder fundus looks like. Now talking about this cherry red spot, you can see one spot in the center. This is known as cherry red spot, and this is seen in CRAO. Now going further, talking about the uveitis, we have discussed the basics of the anatomy. We have discussed the various charts. We have discussed the ulcers. We have discussed the this thing, that is CRAO and CRVO. Now we have discussed trachoma, allergic keratoconjunctivitis. Now we will discuss about the uveitis. So uveitis, basically there are 4 types, I'll say: anterior uveitis, intermediate uveitis, posterior uveitis, and a pan uveitis, that is uveitis of the whole uvea. So now anterior uveitis, that is inflammation of the anterior chamber, right? And it is affecting the iris and the anterior ciliary body only. So what are the conditions seen in the anterior uveitis? It can be iritis, it can be iridocyclitis, and anterior cyclitis. Now talking about the intermediate uveitis, it is the inflammation of vitreous, right? So it manifests as a pars planitis, posterior cyclitis, or hyalitis. Posterior uveitis is the inflammation of retina or choroid, of the retina or choroid, right? So not retina, I should say. It is the inflammation of choroid, and it can cause focal or diffuse choroiditis. Choroid can affect the retina and cause chorioretinitis, retinochoroiditis, etc. kind of thing. And panuveitis is inflammation of the anterior chamber, vitreous, and the retina or choroid. Now talking about the anterior uveitis. Now anterior uveitis, most common causes idiopathic, it is unknown, and the earliest sign of iridocyclitis, that is a manifestation of anterior uveitis, is aqueous cell. Mutton fat erratic precipitates is a sign of a granulomatous uveitis in the anterior uveitis. If the synechiae is formed in anterior uveitis, it might cause a adhesion, right? And if it is an anterior scenic, it will manifest further as a glaucoma, whereas if it is a posterior scenic, it will manifest as a cataract. Now this cataract, if with the posterior scenic, if in posterior scenic, if only some area of pupil is stuck to the lens, the lens will get an irregular shape, and this irregular shaped pupil is known as festooned pupil. And this is how a festooned pupil look like. You can see the shape of the pupil is irregular. Usually it is a circular pupil, but due to the adhesion, the pupil is stuck to the lens at some areas of the pupil is stuck to the lens and the remaining areas are not. So the shape is a bit of irregular, and this is known as festooned pupil, and it is seen in anterior uveitis. Going further, iris nodule. It is a sign. Iris nodule is usually present in granulomatous uveitis. If it is present in on the margins of the pupil, it is known as copious nodule. If it is present at the iris itself, body of the iris, it is called as Busacker's nodule. Right. So this is present on the margin of the pupil. Right. So this is the copious nodule. This one is present on the iris. Right. Body of the iris. This is known as Busacker's nodule. Going further, this is how this one was made by me itself to know how it looks, but actual image is something like this. This is on the margins, you can see, and this is copious nodule. Whereas if you can observe properly this arrow, here are some of the iris nodules on the surface of this iris. So this is known as Busacker's nodule, and this is what is actually this iris nodules. It is an aggregate of epiculoid cell and mononuclear cell. Now talking about the intermediate uveitis, the most common symptoms of the intermediate uveitis is floaters, and the most common cause of this intermediate uveitis, like the anterior uveitis, is idiopathic. The snow banking at the pars plana is the pathognomonies of intermediate uveitis, and loss of vision here also is the reason of loss of vision here also is macular edema, as it was in CRVO, that is central retinal vein occlusion. Now talking about the posterior uveitis. Now posterior uveitis, most common cause overall is toxoplasmosis, whereas the most common infectious cause is also toxoplasmosis. But if the question is asked what is the most common non-infectious cause of this posterior uveitis, then the answer is sarcoidosis. Headlight in fog appearance is typically how the posterior uveitis looks like, and this is the typical appearance of known as headlight in fog appearance, which is seen in posterior uveitis. Now going further, sympathetic ophthalmitis. Okay, it is bilateral on the both eye, granulomatous uveitis. It is usually what happens, the one eye is injured, that is known as exciting eye, and the another eye which was not injured, it will show inflammation in it, and this is the inflamed, the unaffected, the untraumatized eye is inflaming, and this thing is known as sympathetic. Inflammation in other eye is called as sympathizing eye. A site of injury of the sympathetic ophthalmitis is danger zone of eye, that is ciliary region, and this thing is if you see properly, there are few white dots. These white dots are known as Dallen's Fuchs nodule, and these are the sign. This is how a retina, a fundus looks like in sympathetic ophthalmitis. So Dallen Fuchs nodule are small discrete yellowish infiltrates at the level of RPE that are most often seen and are largest in the retinal choroidal periphery. So nothing. Dallen Fuchs nodule, this is the yellowish infiltrates seen in sympathetic ophthalmitis. In sympathetic ophthalmitis, what is happening? Actually, the eye injured, the eye which is injured is not inflaming, whereas the another eye, just to balance it, is getting inflamed, and this is known as sympathetic ophthalmitis. Now this is the visual pathway. Usually the optic nerve It has two components, the nasal and the temporal part. It meets at this junction. This is known as optic chiasma, and further it goes to the visual cortex via optic tract. Now this is how a visual, now let's discuss this visual field defect. Okay, so first, if there is a lesion in the optic nerve, right optic nerve is injured, so that what will happen, the total blindness of right eye will happen due to the complete lesion of the right optic nerve. If the lesion is at optic chiasma, if the lesion is at optic chiasma at the center, this is the center, this is the optic chiasma. If the lesion is at optic chiasma, then the defect will be known as bipolar hemianopia, and this is due to midline chiasmal lesion, right? Midline chiasmal lesion. And the most common cause of bipolar hemianopia is the pituitary adenoma. So I have not mentioned it here. Most common cause of bipolar hemianopia is pituitary adenoma. Now going further, this third point, right? What is happening here? Right perichiasmal area is being blocked, right? Is being defected. So if the right side of the perichiasmal area is defect, so right nasal hemianopia will be seen, and this is been seen due to the lesion involving the right perichiasmal lesion area. Now here, the fourth one, if the optic tract is having any lesion or there is a pressure on the optic tract, what will happen? Left homonymous hemianopia, that is left side of the both eye has been the vision will be defected. Now the fifth thing is this, right? So this is known as left homonymous inferior quadranopia. It is due to the involvement of lower right optic radiation. This is optic radiation. So if the lower optic radiation is involved, then the lower area will be blurred, right? Lower area will be blurred. So this is known as left homonymous. And one more thing, opposite side. If the right optic radiation has been infected, has been traumatized or lesion or pressure, so the left side will be the affected side. So left homonymous inferior quadranopia is occurring due to the involvement of the right lower optic radiations. This is also known as pie on the floor. Now sixth is left homonymous superior quadranopia. Now what will happen here? Once again, the similar way. The optic radiations is been injured on the upper side, right? On the upper side. So if the upper optic radiation has been injured, upper side will be the blur side or the vision which is lost. Now the thing is, once again, if the right side is affected, right optic radiations are affected, the left side of the blindness will be occurring, right? Now seventh is the left homonymous hemianopia due to lesion of the right occipital lobe. If the occipital lobe is getting defected, the lesion will be seen on the another side. This was about the visual field defect. Now talking about the entropion and ectropion of the lower lid. You can see in the center there is a normal eye. Now on this two sides there are two different things. One is entropion, one is ectropion. Now the entropion, what is entropion? It is inward movement. The eyelids, lower eyelids is turning inward, right? So this is known as entropion. If it is turning outward, it will be known as ectropion. So now here you can see this is the normal healthy eye. In entropion you can see more folds here because it is the lower eyelid is turned inward. When it is turning outward, it is known as ectropion, and when it is turning outward, you can see some part of the conjunctiva here. Now MADAROSIS. What is MADAROSIS? It is loss of eyelashes or eyebrow, right? So what are the different causes of MADAROSIS? It is seen in leprosy, syphilis, SLE, and hypothyroidism. If you can see here, this person is not having the upper eyelids. Also, the few eyebrows are been absent for him, are not there to him. So this is known as MADAROSIS. Now talking about some instruments in ophthalmology. First is perimetry. What is the use of perimetry? We use perimetry to test the visual field. Now there are different type of perimetry. First is Goldman's perimeter. It is for both central and peripheral vision. Visual field is central and peripheral. So to measure the central and peripheral, we have different kind of perimeter. For in this, the gold standard perimeter is the Goldman's perimeter. It is for both central and peripheral field vision. Then there comes a Humphreys perimeter. It is an advanced automated perimeter. Next is Jerem's tangent screen. It is for central field, just to check the central field of the patient. Then there is a Lister's perimeter, which is used to check the peripheral field. Now, another thing is confrontation test. In this, what we do, we compare the visual field of the patient with the visual field of the examiner. Now, two important things. On the temporal side, the visual field is maximum, whereas at the superior side, the visual field is minimum or least. Now, this is how a Goldman perimeter looks like. It is used. There can be a question this instrument is used for. So it is used for measuring visual field. Which visual field, central or peripheral? Both. This is Humphreys perimeter. This is the automated perimeter used nowadays. These are two, Derham screen and Lister's perimeter. Derham screen is used for center, whereas Lister is used for peripheral. Now talking about the tonometer. Tonometer is used to measure the intraocular pressure. Normal intraocular pressure is 10 to 21, sorry, and average will find it around 16. Now this intraocular pressure of eye is having diurnal variations. That is, in morning it is something else, in evening it is something else. So at what time it is highest? It is highest in early morning, whereas in the evening it is less. Now this is how a tonometer looks like. This is used to measure the intraocular pressure, right? So this is a connected to the slit lamp from where the observer checks. This is the biprism which goes till the cornea. This is a feeder arm. Then there is a control rate, housing, and adjusting knob, right? So this is how a tonometer looks like. Once again, and this image can be given, and you may be asked this instrument is used for. So this instrument is used to measure the intraocular pressure, and it is known as tonometer. So this is how the actual tonometry test is done. You can see. Going further about tonopen. Tonopen is nothing but an advanced tonometer, right? This is how a tonometer looks like. When you compare, this is how a tonometry was used earlier, and now this is how it is done. So this is the advancement in the tonometry to measure the intraocular pressure. You can see here there is a digital area where we can measure the intraocular pressure, where we can see the intraocular pressure directly. So this was all in this part of this video. Hope you find it useful. So please like, share, and subscribe my channel, Meddy Simplified. And the other parts, that other topics, that is glaucoma and cataract and refraction error, these topics I'll be discussing in the another part of this video.